For over a century, the New England Journal of Medicine has presented a weekly clinico-pathological conference, or CPC, which is the ultimate test of clinical reasoning. Each week, an expert clinician is given a complex, anonymised case and has to work out the diagnosis in front of the world. But a case published just this week did something new. Alongside the traditional master clinician, there was a second discussant, an AI called Dr. CaBot. So today we're looking at the project behind this AI, and a landmark paper published as a preprint earlier last month called Advancing Medical Artificial Intelligence Using a Century of Cases. And what I love about this is that they're taking on a genuinely tough problem. For decades, the goal of diagnostic AI has been to produce a ranked list of probabilities, but that's not what a real expert does. A real expert tells a story. They weigh evidence, they build a narrative, and they communicate their reasoning with nuance and conviction. The ambition here is to create an AI that doesn't just get the answer right, but that masters the art of clinical reasoning itself. And the results are genuinely impressive. The paper introduces something called CPC Bench, a new benchmark built from over 7,000 of these historical CPC clinical cases. Against this, their AI models are outperforming physicians on complex text-based diagnoses. In one test, for example, their model got a correct diagnosis in its top 10 suggestions 84% of the time, compared to a baseline of 45% for a group of 20 human doctors. Even more strikingly, the project also created a video presentation of the AI's reasoning. And while no individual part of this, text-to-speech, slide generation, is necessarily new technology, there's something about seeing a human-like avatar presenting a compelling clinical narrative that feels like a genuine step change. This week's New England Journal of Medicine case gives a perfect snapshot of this in action. So the case was a 36-year-old man with sepsis and a specific bacteremia, lung opacities and a blood clot in his renal vein. The human expert, Dr. Gurpreet Dhaliwal, performed a masterclass in reasoning, linking the patient's history of binge drinking to a moment of impaired control over his airway and digestive tract, leading him to the brilliant correct diagnosis of a perforated duodenum caused by an accidentally swallowed wooden toothpick. Dr. CaBot, the AI, was also remarkably astute. It correctly identified that a perforated duodenum was the source of the whole cascade of problems. But it proposed a more common cause, a penetrating ulcer. So it got the what and the where spot on, but it missed the elegant unifying why, that toothpick. It was an incredibly strong, clinically sound analysis, but just lacked that final creative spark. So the vision is compelling, but a polished journal case is one thing and a Tuesday morning clinic is another. That's the what. The real question for anyone on the front line is the how. The entire concept hinges on its ability to move from the pristine, curated world of a CPC case into the messy reality of clinical practice. A real patient case is a chaotic storm of information. The critical challenge isn't just making the AI smarter. It's about teaching it to reason amidst a lot of noisy information. So how to bridge that gap? I think a powerful approach is potentially to think about reframing the tool as a diagnostic co-pilot, and the goal maybe shouldn't be to produce a final polished report, but to maybe act as a kind of sparring partner that improves a clinician's own reasoning. Imagine an AI that ingests live data from a health record and instead of giving answers, challenges us with targeted questions like the patient's inflammatory markers are rising and the initial scan was normal. Have we considered a non-infectious inflammatory cause? This could shift the AI from being an oracle to being a tool that scaffolds our own thinking and challenges us to prevent things like diagnostic momentum taking hold and human cognitive biases from impairing our reasoning. So Dr. CaBot and the CPC Bench projects are a really great demonstration of how the field's moving and the goalposts are changing from can this AI get the right diagnosis to how can we best partner with that AI that can reason. The challenge is no longer about raw intelligence, it's about thoughtful integration into the complex human world of medicine. And the path forward isn't necessarily to replicate the expert discussant, but to build a co-pilot that helps every doctor reason a little bit more like one in the messy workflow of real clinical practice.